Good day and welcome to Flexor Tendon Injuries, Past to Present. My name is Monique Keller, and in this PowerPoint presentation, I'm going to go through what flexor tendon injury protocols have been used in the past and what is used in the present. Here is a collage of pictures to show you how a tendon repair will look, splints that can be used, the loss of the cascade of a finger, and a hand on an operating table. Just as a collage of pictures before we get going with our anatomy. As you well know, anatomy is crucial to understand and appropriately manage injuries of the hand, even musculoskeletal injuries. So let us take a look at the anatomy of the flexors of the fingers and the wrist. Here on your left, you can see that we have the pronator teres muscle, flexor carpi radialis muscle, palmaris longus, and flexor carpi ulnaris muscles. But deeper to them lies the FDS, flexor digitorum superficialis, and FDP, flexor digitorum profundus. The superficialis muscle splits into tendons and runs superficially through the carpal tunnel and the transverse carpal ligament, just underneath them. Deep to that, the FDS runs the FDP. The FDP runs all the way and inserts into the distal phalanx, where it flexes the distal phalanx of the fingers. Don't forget that you also have your flexor pollicis longus muscle that runs to the thumb and flexes the thumb. In this slide, the palmar or volar view of the wrist, bit of the distal part of the forearm, and the hand, you can see how the flexor tendons, which originate from the medial epicondyle of the humerus, moves distally. Some of them inserting and not going through the carpal tunnel or underneath the flexor retinaculum, like pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. They are predominantly the flexors of the wrist, which can also get injured or cut. But the tendons running underneath the flexor retinaculum and entering the carpal tunnel are the following. Flexor pollicis longus going to the thumb, flexor digitorum profundus situated deep, flexor digitorum superficialis that are superficial when running through the carpal, underneath the carpal tunnel, which inserts into the middle phalanx and is responsible for flexion of the PIP. FDP then moves more superficially at the PIP, the middle phalanx level, and inserts into the distal phalanx to flex the DIPs. Here you can also see that in a flexor tendon injury, it is not only the tendons that can get injured. You can clearly see there are arteries, the radial artery on the radial side, the ulnar artery on the ulnar side, which enters into the hand and forms the superficial palmar arterial arch. And also clearly the nerves, the median nerve running underneath the flexor retinaculum and also situated in the carpal tunnel. When taking off the skin and the superficial fascial layer of the palmar volar part of the hand, you can see that it is jam-packed. There's very, very little room because of all the structures that are contained in the hand. So when you look at how can the tendons move so smoothly in the hand and flex your fingers? Well, as you can see, they are surrounded by bursas. There's an ulnar bursa and a radial bursa. Radial bursa, which contains the flexor pollicis longus. Then you can also see when you look at the fingers that each tendon going, or the tendons in combination, FDS, FDP running into the finger, each digit has its own bursa. It's almost like the tendon is sitting in a balloon that moves on its, and the two layers of the balloon, which encases the tendon, moves over each other. So that's why they can move so smoothly. But you can see very tight. And in the past, very interesting fact, in the past, people believe that you actually need adhesions after a tendon has been repaired to facilitate healing. But as we now know, that is not the case, and that adhesions actually limit movement of the tendon, actually restricts it as that adhesion tries to move through the pulleys, the annular and the cruciate pulleys. So we don't want, there's more than enough circulation from the vincula, longus and brevis, that sends blood and also the synovium to facilitate healing. So for that reason, we don't want that adhesions limiting movement. Also visible here, you can see that there's the thenar muscles of the thumb, the hypothenar muscles going to the little finger, digita minimi, and also the lumbricals and the interosseous, the intrinsic muscles. When you look at the bottom to the right, there you can see the annular and cruciate pulleys that holds the tendon and its bursa down. A2, A4 pulleys are crucial to prevent that tendon from, when the finger flexes, at the tendon bowstrings, that it moves away from the digit and the bone. So yeah, let's move on and look at the anatomy of the pulleys. In the top picture, here you can see the annular pulleys from A1 to A5. Annular from the shape that they are in, and it is clear that they give support and maintains the contact of the tendon close to the bone. Where the cruciate pulleys, with its cross form from C1 to C0, 1, 2, and 3, gives us an indication of how it also allows range of motion as the finger flexes and extends, but more so with flexion. Also importantly, the collateral ligaments, you can see. And looking at the complexity of a digit from a side-on view, as seen below, you can see how the interosseous and the lumbrical muscles that actually moves from a palmar origin moves and inserts dorsally. And that is also why it gives us, when you flex your MCPJs, why your PIP and DIP is actually extended, that lumbrical grip. It's because all the muscles that originate, that intrinsic muscles originating inside the hand, in the palmar surface of the hand, moves and inserts dorsally into the extensor hood. You can also here see how the FDS inserts into the middle phalanx and how the FDP moves through the two slits and through and moves all the way to the distal phalanx to insert and flex the DIP. How does a flexor tendon injury present? Well, there are obviously a cut to a finger or a number of fingers in the palm or in the forearm that's visible, either with a knife, can be a sharp knife like a butcher's knife, a person slicing some biltong, or it can be a saw, a work injury where it's jagged, where the skin is actually torn and the ligament and the tendons are disrupted and there's not clear, clean edges. But then also get what we call a jersey finger. That is not an open injury, but a closed flexor tendon injury. Like for instance, a rugby player running behind an opponent and just catching his jersey, his rugby jersey, with an index finger, and the person still moves forward, and that FDP tendon can avulse, meaning take a piece of bone, or it can be a tendon injury in itself. That is a closed finger, and with my explanation, I hope you can understand how it's a jersey finger coming from a rugby jersey. So how does it then present? When you look at the hand, you can often see that that finger that's injured is not in its normal position. So when you supinate your hand, can you see how your fingers naturally fall into a relaxed flex position? And where the fingernails, if you draw a straight line with the fingernails, that it should all connect to the scaphoid. Can you see that? Well, there's a loss of cascade. So that finger that's injured, that tendon, finger that's had a tendon, flexor tendon injury, is not in that natural cascade anymore. So there are tests to see if an FDS or FDP tendon is lacerated. But take care to not put stretch on it. So be very careful, or else you will just cause that tendon to retract further away. To test for an FDS, let's say the middle finger, you have to stabilize the ring, index and little finger and just ask for that one finger to the person to move the PIP inflection. For an FDP injury, suspected injury, you're going to block the PIP and ask them to simply flex the DIP. And then you will, if they are unable to do that, then you know there is a possible tendon injury. The flexor zones of the hands are as follows. Zone 1, distal to the insertion of the FDS. Zone 2. Zone 2 is between the distal palmar crease and the FDS insertion. Zone 3, between the distal palmar crease and the carpal tunnel. Zone 4 lies over the carpal tunnel. Zone 5 is the area proximal to the carpal tunnel, including the forearm. So why do we have flexor zones? Well, this makes communication easier to communicate where the cut or where the tendon is lacerated in. We have looked at some of the mechanism of injury before, but let's go over it again. How can a flexor tendon injury occur? Can be a cut, a laceration, on the flexor surface, on the palmar surface of the hand in any of the 5 zones mentioned previously. The laceration can be smooth, a sharp knife versus a jagged edges, like for instance instruments at work, grinders, saws, or the jersey finger, where the FDP rupture at or near the insertion of the distal phalanx. It can be an avulsion of a piece of the phalangeal bone, and it occurs when the finger is caught and pulled, usually in a bit of hyperextension of the DIP joint, while the PIP joint is flexed, so a forced extension of the flexed finger occurs. So, when the FDP ruptures, for instance in a jersey finger, and it is within a centimeter of the insertion, then the surgeons will often anchor the tendon into the bone by using a suture, sometimes that runs through the nail, where they put a little button and then tie the suture on, or the avulsion piece gets anchored into the bone, fixated there. So a flexor tendon repair. When the surgeon brings the 2 edges of the tendon together and have to suture between the 2 tendons, it's a difficult surgical repair. And it should be done timelessly after the injury to prevent retraction of the tendon further into the forearm or into the carpal tunnel. And it's difficult because there's often excessive scarring to retract that tendon back. So we talk about the sutures, the strands that crosses the tendons from the one tendon to the other tendon. How many strands actually crosses the 2 tendons in a repair? If it's a 2-strand repair, then it interlocks twice between the tendons. If it's a 4-strand repair, 4 times. So here you can see that there's different types of repairs, but a 4-strand repair is sufficiently strong for early active mobilization, your early active protocols, where a 2-strand is not strong enough for an early active, but for an early passive program. So how much force can a repair actually take? Strickland did some fascinating research which he published in 1993, where he indicated that a two-strand repair at 0 weeks can take 2,500 grams of force without tearing the tendon. At 1 week, you can see that there's a decrease where the tendon is slightly weaker and actually significantly weaker, where it can only handle 1,250 grams of force. Then it gradually becomes stronger again at 3 weeks, 1,700 grams, and at 6 weeks, 2,700 grams. Let's now look at a 4-strand repair. At 0 weeks, it's already significantly stronger than a 2-strand repair at 4,300 grams. So for this reason, with a 4-strand repair, early active protocols can be commenced as soon as that first 3 days of inflammation settles. However, a 2-strand repair will not handle early active, and that is why with a 2-strand repair, early passive protocols can be used. Interesting also, at 1 week with a 4-strand, it loses a bit of strength, 2,150 grams, and then gradually regains the amount of force that it can handle, and at 6 weeks it can handle 5,200 grams. What are the goals after a flexor tendon repair? Why do we have all these protocols? And a wide variety of different protocols, I may add. While the goals remain the same. It is to decrease adhesions. That is why it is preferred to move away from immobilization more to a passive, and these days an active protocol with at least a 4-strand repair. It is because we don't need the adhesions, we don't want them because they limit ROM function and quality of life. We want to prevent gapping between the two tendon ends that's just been sutured. We want to gradually increase the tensile strength, the strength that the tendon can handle, and of course prevent re-rupturing of the tendon. We want to maintain the integrity of the repair while still decreasing adhesions and gradually building tensile strength. And this is demanding. It takes many hours, and many of the protocols, at least every 1 hour of when they are awake, the patients are instructed to do their home exercises. So now the question is, but which of the 3 categories do you decide to use? And in, like for instance, the early passive, early active, which protocol? Well, before we can decide on the protocol, you have to know if you can do an immobilization, if that's needed, or an early passive motion or an early active motion. So, what criteria can you use? Definitely age, the zone of the injury, where the injury has occurred in the hand, the quality of the surgery, the patient's place of residence. Are they close to your practice or the hospital, or are they far away? And that indicates if they can come to therapy once a week, maybe twice a week, or only once a month, which is not preferred. The comprehension and compliance of the client, the time of referral to your practice. So, let's take a look. In a child younger than 10 years old, immobilization for about 3 weeks is indicated. Because we all know children, they run around, they play, and the tendon may get hurt. When the strength, the quality of the surgery and the strength of that repair is questionable, immobilization can be considered. If they live too far away for weekly visits, there's poor comprehension, and there's been a delayed to referral to the hand clinic or your practice more than 2 weeks, you already know that that tendon has adhesions that's limiting movement. So when can we consider using early passive motion protocols? Clients older than 10 years, because they should understand the principles in zones 2 to 5, when there's been at least a 2-strand repair, quality is excellent, they live close enough for weekly visits, they can understand the principles and comply with the protocol. And when the time of referral is early, 1 to 4 days after operation. Early active motion in clients older than 14 years, they should clearly understand the principles and precautions. In zones 2 to 5, 4-strand repair and even a 6-strand repair, although some sources say it can be too bulky, but a 6-strand repair will definitely handle and be safe. You want to use early active motion protocols. They have to be able to return at least twice per week for their session. Understanding is clear, and the referral to your practice is in the first 3 days after the operation. So you may be asking, but immobilization, so what is that? Well, that is when the hand gets immobilized for a period of at least 3 weeks in a POP, in a safe position where that tendon heals. There's no early passive or no early active motion. Of course, you can give therapy advice, elevation for edema management as well, but this is definitely not the preferred method because adhesions will form and ROM will become and will be a challenge. Early passive motion. So what do we do there? Early passive motion is started in where you passively flex the fingers individually, one at a time, passively flex them, and they can actively extend up to the dorsal blocking splint. Then you can also include passive composite flexion and actively extend all the fingers up to the splint. where early active motion is commenced from the start, but gradual early active motion, not a full fist. Research shows us that even place and hold is not the preferred method, but we will go through this in the protocols which will follow. You may have heard about the term no man's land, an unoccupied or disputed area or ground between two armies. Well, the zone 2, if you have a flexor tendon injury in zone 2 is also known as no man's land. It's because the FDS and the FDP run so closely together in an already confined space. It's so susceptible to adhesions that it is called no man's land. And sometimes in surgery, do you repair both the FDS and the FDP, or just the FDP that runs all the way distally to the distal phalanx? Well, those are the tricky situations and the decisions that the surgeons will make in theatre. During a flexor tendon injury, it is not only the tendon that can get injured. Think about what lies next on both sides of the tendon, the digital nerves, as well as the pulleys that keep the tendon close to the bone. Here in this example, you will see that one of the very important pulleys has not been repaired, the A2 pulley. And what happens then is bowstringing. You can see how the tendon lifts into the palm and is not in close connection with the bone anymore. So it is important to repair the A2 and the A4 pulleys, as they are crucial in preventing bowstringing. If there's a digital nerve repair, discuss this with your surgeon. If you want to place that nerve, so that digit, in slight flexion for 2 to 3 weeks to give that nerve adequate time to heal. Starting with the immobilization protocol. The rationale for using it is for cognitively impaired individuals, clients that you know won't adhere to protocols that are more advanced, and also children under the age of 10 to 12. Use your judgment for them. So in the early stages, the hand will be immobilized in a dorsal blocking orthosis or a plaster of Paris cast, with the wrist in flexion 10 to 30 degrees, the MPJs also in flexion at about 40 to 60 degrees, the IPJs in full extension. If therapy is provided, then it's passive flexion of the digits only, with mobilization of the uninvolved joints, and then later on wound and scar management as well. So then looking at the intermediate stage after the orthosis can then be modified, where the wrist is changed to more neutral position and it is then removed for hourly exercises from about 3 to 4 weeks after the first initial immobilization stage. Passive flexion will then be continued or commenced with the wrist in slight extension. But be gentle at this stage because remember the tendon has been immobilized and the hand has been immobilized, so the tendon is weaker than what it would be in the early passive or early active protocols. When you start after removal of the orthosis and you start with your passive movements, do an assessment. Measure the MPJs, the PIPs, and the DIPJs. For flexion, so you're going to use your goniometer and assess their passive flexion and also then their active flexion at about 4 weeks onward. Then you're going to determine the total active motion, the TAM of the digit, and the total passive movement of each digit. That meaning your index finger, your middle finger, ring finger, little finger. But remember, this applies more to the involved fingers as well. So if you had a zone 2 flexor tendon injury in your index and middle finger, these are the digits that we are talking about now. If there's more than 50-degree difference between active and passive, then progress onward to the next stage. So then you progress your rehabilitation. That means if your passive movement, where you passively flex that digit, is much more, 50 degrees more in total movement compared to when the client actively moves, that tells us that there are adhesions at play and that you should progress faster, or else the adhesions will just limit range of motion that much more. But on the contrary, if the difference is less than 50 degrees, continue with the phase that you are in until 6 weeks. Later stage, from about 6 weeks onwards, the dorsal blocking orthosis can be discarded. And from the year on, you can start, if you see that the range of motion is limited, you can then start with splinting, serial casting to gain that range of motion. Remember, start gradually and progress the range of motion splinting to gain extension. When looking at early passive mobilization protocols, we will be looking at 2 protocols. The Duran, that was also modified to the modified Duran, and the Kleinet. In the Duran, you have your dorsal blocking splint, and passive exercise, extension and flexion of the digits are used as an exercise called as the Duran and Hauser exercise, where when you do that, when you give that to your clients, they get a 3 to 5 millimeter of tendon excursion. And gentle active motion is commenced at 4 to 5 weeks. so it is predominantly passive. It is just that your Duran and Hauser exercise that I will explain to you in a bit. A clinet is also a dorsal blocking splint. Early passive individual digital passive movements are started, as well as composite passives of the fingers, but there's rubber band attachments which flexes the fingers within the dorsal blocking splint, and the clients then perform active extension within that splint. Contractures, however, are a major concern. Before discussing the modified Duran protocol, let us first look at the original Duran and Hauser Flexor Tendon protocol. So here the orthosis placed was a dorsal blocking orthosis, placing the wrist in flexion of 20 degrees, MPJs in a relaxed, flexed position, but the orthoses only were made up to the PIP joints, where with the modified Duran, it's extended past the PIPJs up to the DIPJs and beyond. So it includes all the affected fingers. So the original orthosis, there were rubber band tractions applied to the injured fingers during the day, and the fingers were then placed at night back onto the dorsal blocking splint. So let's look at the original Duran and Hauser exercises. It's prescribed at 2 times a day within the dorsal blocking orthosis, and the exercises to be repeated 6 to 8 repetitions. Here, the passive extension of the DIPJ is done, but while the PIPJ is held in passive flexion. So that hand is, the PIPJ is placed in flexion, and while it is there, there's an extension, passive extension on the DIPJ. Also the opposite, where there's the DIPJ rests in flexion and the PIPJ is then extended. The original Duran and Hauser is then progressed from 4.5 weeks, where the dorsal blocking splint is replaced with a wristband, which includes a rubber traction band. Exercises to be done every 2 hours, 10 repetitions, and the tenodesis of the wrist is used in this exercise. As you extend your wrist, the fingers gradually flexes, and also as you flex the wrist, the fingers gradually extends. So still on the original Duran and Hauser, at 5.5 weeks, exercises or repetitions increase to 10 to 12 reps every hour. But here the wristband is removed and active flexion is then started. Gentle blocking, composite fist, and FDS gliding as well. Always do remember that the passive flexion in composite passive flexion of all the digits, as well as individual passive flexion of all the digits, just to warm up as you are starting your rehabilitation for the day. So now already we've discussed how the modified Duran orthosis is made, where it's extended past the PIPJs, up and above, up and beyond the DIPJs. So in the first 3 to 5 days, edema control is very important. Advise your clients to elevate the arm above the hand. They can use pillows and do this intermittently throughout the day. Your passive extension and flexion with the Duran and Hauser can be commenced with care. From 10 to 14 days, if there's pain, the wound is healing well, heat can be applied, and also the scar management can gradually commence. If there's still sutures in, sutures will have to then be removed, but make sure that the wound is closed at this stage. If it's not and the sutures are still in, start your skull massage a bit away from the actual scar, but still around the area. At 3 weeks, place and hold exercises are commenced within the dorsal blocking splint. Remember from in the first phase, also the passive movements into flexion that we discussed. At 4 weeks, the modified Duran starts including tendon gliding exercises. Ultrasound can be commenced, and the dorsal blocking splint is stopped at 5 weeks. All the previously mentioned exercises are still continued, as well as the tendon gliding exercises. At 6 weeks, passive extension can be started, where a dynamic night splint can be applied to improve the limited range of motion. Here also blocking exercises can be commenced. Blocking of the DIPJ, or where you block the finger except the DIPJ, then you do flexion. Where you block the MPJs, there you do flexion of your PIP. So all the uninvolved or the joints that you don't want to exercise, where you want to isolate, for instance, the flexion of the PIP, then you block all the joints below that. From 8 weeks, strengthening is commenced. Do take care to not start strengthening with, for instance, a black TheraBand, right? Or strengthening with therapy that are stronger. So start with your lighter weights, even sponge squeezes, and then progressively build up the strengthening. For the early passive modified Kleinert protocol, let's look at the splint fabrication first. It's a dorsal blocking orthosis with the wrist in 45 degrees of flexion, the MPJs in 40 degrees of flexion, and the IPJs allowed to fully extend. But there's a rubber band traction that gets applied from the fingernail. Then it moves underneath a rolling bar at the palm and a coiled lever at the forearm. At this stage, extension of the digits can be performed against the rubber band traction up to the dorsal blocking orthosis. So it's basically against the rubber band from when the splint is applied up to 4 to 6 weeks. From 10 to 14 days, heat modalities can be applied if it is very painful and not over open wounds. At this stage, if the sutures are still in, the sutures can be removed. Scar massage can also be commenced. From week 3 to 6, the orthosis can be removed for wrist exercises at 4 weeks. And then to begin gentle active flexion. Also remember your passive flexion of the digits, composite, and each individual finger. By 5 weeks, active tendon gliding is commenced. At 6 weeks, this orthosis is discontinued. The client can start with light function, and the tendon gliding exercises can be continued. From week 6 onwards, active assisted ROM can be started at 7 weeks, and then also gentle resistance can be applied. Now we come to the early active motion protocols, which have become more common, but there's different splint designs, and there are a wide variety of different protocols for early active motion. Remember that a 4-strand repair is crucial or a 6-strand repair. At times, a 6-strand repair can be a bit too bulky, which can also affect the gliding of the tendon between the pulley, but at least a 4-strand. And it's not to say that a 6-strand repair is always too bulky. Also depends on the suture material and of course the skill of the hand surgeon. Your patient must be compliant and understand exactly what is expected of them. It's also very demanding for them. They have to be motivated so that they can do their exercises every hour, every waking hour. The best is to wait 3 to 5 days as to let any inflammation settle. Because if you start too early, before 3 days, you can actually cause more bleeding, which then eventually will lead to adhesions. So wait up to 3 days before you commence with your early active motion protocol. The Indiana protocol will now be discussed. At day 3, a dorsal blocking splint will be fabricated with the wrist in 20 degrees of flexion, MPJs in 50 degrees of flexion, and IPJs full extended. Then another orthosis will be made, which is called the synergistic orthosis with a hinge. And it allows full wrist flexion and up to 30 degrees of wrist extension. But the MPJs is blocked at 60 degrees of flexion. And again, the IPJ is allowed to 0 extension. From day 3 onwards, passive range of motion should be done 15 reps every exercise session at the PIPJ, DIPJ, and as well as the entire digit. The dorsal blocking orthosis should be worn for 24/7, but every hour it is to be removed. The synergistic hinge orthotic should be applied, and then the following exercise should be done. Like I said, every hour. 25 reps of place and hold, where the fingers are passively flexed while the wrist is simultaneously extended. At this position, the fingers, you give the instruction, hold the fingers in this flexed position for 5 seconds. And then the opposite is done where the wrist is flexed and the fingers then automatically extends. So from 10 to 14 days, scar management. If the sutures are not yet removed, make sure the wound is adequately closed, remove the sutures, and then continue with your scar management. Firstly, around the scar. As the scar heals, then progress your scar massage closer to the scar. At 4 weeks, leave the synergistic splint, but continue with the dorsal blocking splint between exercises. Continue still with the previously mentioned exercises, but add active range of motion, finger, light movements, 25 repetitions in each exercise session. Avoid finger and wrist extension as a combined movement. From week 5, continue with your exercises as per week 4, but here add your tendon gliding and hook fist. Week 6, here discontinue your dorsal blocking orthosis, but add joint blocking except for the little finger DIPJ. At 7 weeks, add passive extension, and here gentle progressive strengthening can be started. Week 8, light resistance. From 14 weeks, normal activity can be returned to. Recent research has indicated that place and hold exercises in the early active motion protocols can be detrimental to the healing of the tendon. So the St. John's protocol proposes a different way, a safer way of going about early active motion for flexor tendon healings. Let's go through it. So first, wait up to 3 to 5 days, where dorsal blocking orthosis with a wrist in 45 degrees extension, MPJ's 30 degrees of flexion, and IPJ's full extension position for the orthosis. Control the edema through elevation of the limb higher than the heart, or Coban and Coban compression. From 4 to 14 days, give your client the instruction to move it, but not use it. Move it, but don't use it. Passive flexion of each finger should be done as a warm-up. Active IPJ extension with your MCPJs in flexion. Then, very importantly, active third to a half fist in the splint is commenced, where the fist third to a half is started at the DIPJ flexion. You have to give clear advice when they start making their fist that it's only up to half, but start with a third, and they have to start by flexing their DIPJ so that they learn how to recruit the DIPJ flexion from an early stage. Repeat this 10 times every waking hour. From 2 to 4 weeks, the dorsal blocking splint is shortened to a Manchester short splint, where the wrist is not included in the orthosis. Active synergistic exercises in the Manchester splint. Also from 2 to 4 weeks, active half of a fist to full fist can be progressed, and wrist active movement up to 45 degrees of extension. Full IPJ extension with MCPJs in full flexion. At 6 weeks, stop the Manchester short splint. Full fist position is worked to. Light activities are started. From week 6 to week 8, the short palm or hand-based or finger extension splint can be made and applied to increase the range of motion if there is a limited of extension ROM. Relative motion flexion orthosis can also be useful in the day. From week 8, strengthening can be commenced. So the take-home message is that there are protocols that can be followed. You have to carefully decide with your surgeon and in your hand therapy team which protocol is best suited for your client with their individual needs, where they stay, how often they can come for therapy, how compliant they are, how much they can understand what is expected of them to get the best rehabilitation and function after a period of 4 months. So it is important to realize that there's careful exercise progression according to a protocol for the rehabilitation after a flexor tendon repair. Rehabilitating your first client who have had a flexor tendon injury and had a repair and now sits in front of you can be quite daunting. But here I want to give you guidance on the amount of force in grams that you can use to see when you do, for instance, Duran and Hauser exercise in the Duran protocol. That only places 400 grams of force on the tendon. And then you can use the 2 and 4 strand repair strength as a guidance to see, but can the tendon withstand that when you do the correct application of that exercise? Can the tendon withstand under normal conditions the force you are applying? This now also depends if there's a possible infection. Remember, an infection decreases the strength of the tendon. So let's take a look. On the left-hand side, you will see that there's an arrow going down, pointing down, and it starts with a minus, meaning the least forces, to a plus sign in red. That means the most force on the tendon. So let's take the The first in the triangle. Passive flexion and protected extension of the fingers up to the dorsal blocking orthosis is very, very little force and is safe early on. Place an active hold synergistic flexion is 900 grams of force on the tendon. You can see how it progressively, with what we are doing now, like a straight fist, places more force on the tendon. So straight fist is 1,100 grams on the tendon. So if you do this, a straight fist with a 2-strand repair, at 1 week, you are close to the limit of that tendon, and that's not advised. A hook fist is up to 1,300 grams, and you can see how that is definitely safe. At 3 weeks, for instance, definitely safe with a 4-strand repair. Isolated joint motion, blocking exercises is more force, 1,900. An active composite fist is the danger. It can be up to 4,000 grams, and you can see that that is enough to injure and re-rupture the tendon. More force with resisted composite fist and thereafter resisted blocking exercises. Here's a few examples of exercises that you may find in protocols. In most of them, you will find the passive digit flexion or composite flexion or individual flexion, as is in the first picture on the left. Then the place and hold exercise. In the next picture, the third picture, where there's an A and B, is the Duran and Hauser exercise. In A, you can see that they place the PIPJ in flexion and only then extends the DIPJs. And in B, you can see that the DIPJ is flexed, and only then, when that has been done, the PIPJ is extended. This is done to give a few millimeters of tendon excursion and to attempt to prevent adhesions. The last picture on the right is an illustration of tenodesis. Tenodesis is when you extend your wrist. You can try it on your own wrist. The fingers automatically falls into slight flexion. The opposite is when you flex the wrist, the fingers then moves into more extension. This is tenodesis. What happens if there's been a delay in the tendon reconstruction or repair, or it has been neglected? The patient assumed that they got hurt, but it wasn't too serious, so they only presented at a later stage. Or the tendon has ruptured after a primary repair. Well, then a 2-stage tendon reconstruction will be done. Only if there's not a loss of full passive range of motion. So if the finger is stiff, you cannot passively flex the finger through full range of motion or passively extend a finger, and that there's adequate and enough passive range of motion or full passive range of motion, a staged tendon reconstruction will not be considered. The stages are: first, an insertion of the hunter's rod to again establish the pulley system. Remember that pulleys would have been adhered to the underlying structures, and the tunnel will not be present anymore. So the tunnel first have to be reconstructed with inserting a hunter's rod. Second stage is a tendon grafting from another area, and that is performed at least 3 months after stage 1. So the hunter's rod that is inserted where the tendon has been ruptured or re-ruptured can be an active versus a passive hunter's rod. An active meaning that it is inserted at its distal and proximal ends. This is seldomly performed, especially in the working class, but more so with individuals who need that finger excursion and precision, like for instance, violinists, piano players, artists that really need that fine excursion of the fingers. Here, a dorsal blocking splint will be applied for 3 weeks. Passive range of motion commenced early. Remember that the rod is not a steel rod where the patients often are concerned that they can't move their finger because there's a rod in. It's pliable and flexible. So always advise them in this regard. A passive hunter's rod is connected only to one end of the finger. It's more common, splint is not necessary, and passive ROM is started as early as 1 week after the surgery. Scar massage also very important, because remember here the scar will be cut over on the same scar again, and that means that there can be more adhesions. So scar management is crucial in these patients. The goal is good joint mobility. And hereafter, after the insertion of the rod, the stage 2, your rehab has to be discussed with your surgeon and your team, which protocol you will follow, and then it will be the same protocol as that you will follow as when a primary repair has been performed. I hope you found value in this flexor tendon rehabilitation and protocol presentation. Thank you for listening, and remember, always know exactly what you have to do at what stage, and enjoy your hand therapy. It still is the most fun part of the body to rehabilitate, is the hand and upper limb. Take care.